we risk stratify every case and how we can say this case should have an ICD, this case should not have an ICD. This is the main topic of my talk today. Some of the audience have seen this slide before. It's an aphorism from Hippocrates 2,400 years ago that says that those who are subject to frequent and severe fainting attacks without obvious cause die suddenly. This sounds very obvious and common wisdom. However, it took us 2,400 years to come up with the same conclusion, and I hope that I'll convince you that we still follow the same aphorism as what Hippocrates said 2,400 years ago. So who were the subjects that Hippocrates was discussing? When the medical historians dissected this aphorism, they said that most probably he was discussing cases he had seen that had maybe short QT, that had hypertrophic cardiomyopathy with normal phenotype, or that was structured like with no dyspnea, congenital coronary artery syndromes, and arrhythmogenic right ventricular cardiomyopathy. These can all cause sudden death and beyond. And if we dissect the primary cardiomyopathies, we know that there are genetic causes of cardiomyopathies like HOCM, RBC, left ventricular non-compaction, and also in that category we have the ion channel disorders such as long QT syndrome, Brugada syndrome, short QT syndrome, CVPT, and the Asian sons. We all know that in the action potential, just to keep it very simple, we have sodium that goes in and that causes the depolarization, and then we have potassium coming out that causes the repolarization, and somewhere in the middle we have some potassium going out and some calcium going in, and that keeps the plateau. So if I have a problem with the potassium, for example, that is going slower than usual, I'll have a prolongation of the repolarization. That will cause a long QT syndrome. And if I have a problem with the sodium, that will cause a delay in the depolarization. That will cause a J-wave syndrome. And maybe in the early repolarization phase of the J-wave syndrome, that will be the talk of Dr. Hussein. From a basic electrophysiological principle, it has I just want to point at one thing only for today's talk, is that there is something called the alpha subunit and the beta subunit of the protein of the channel. And the alpha subunit is really where the domain where the ions go in and go out. So if I read about a rare disease that's caused by a gene that affects the alpha subunit, most probably this disease will be severe. But if I see that this gene does not affect the alpha subunit of the disease, but it affects the beta subunit, this will make the disease even more rare, and most probably it will be a mild form of the disease. This is an important concept, and if anyone is interested in the genomes of the channelopathies, we can have, there's multiple articles making this comparison. I'm not going to go through these. I thought I had more time. We just start with, from a clinical point of view, we have two types of long QTs, the autosomal dominant long QT syndrome and the autosomal recessive. The Europeans and Dr. John Oliver also in the States, most probably you'll see a lot of autosomal dominant long QTs. And that's because they have a good screening program where everyone that, not everyone, but some of the children that may have a syncope or that do severe athletic activity can have an ECG, and that's where they pick up that phenotype. And most of them are genetically autosomal dominant, transmitted diseases marked by QT prolongation, episodes of syncope, and sudden death due to dorsal. There are three major long QT syndromes in that sense of the autosomal dominant, which is a long QT1, long QT2, and long QT3. The long QT1, which is the most common, is caused by potassium channel mutation in the potassium channel NQ1, and that slows the slow refractory potassium current, and that accounts for about 35% of the long QTs. It's important from a clinical point of view to see what is the difference between long QT1 and long QT2 and long QT3, is that in the long QT1, in the ECG, we have a broad-based T wave, while in long QT2, you have like a bifid small T wave at the end of the QT interval. And in long QT3, which is not a potassium channelopathy, but rather a sodium channelopathy, you have a prolonged QT, like a flat QT interval, and then you have a sharp T wave at the end of the QT interval. For those who are going into exams, the young people in the back, it's easy to know the difference is that long QT1 and long QT2 are usually caused by potassium channelopathy, and it affects females more than males. And the syncope and the sudden death will happen during either awakening or during activity. In long QT1, it usually happens while the person is swimming, and long QT2 usually happens while the person has some auditory response, like auditory stimulus, like a loud noise or something. And both happen more in females. Long QT3, as it's sodium channelopathy, and we'll also see that Brugada syndrome is also a sodium channelopathy, it affects males more. And it affects most probably as we usually suffer in silence. So, so usually men die at peace at home while they are asleep. They don't make that much of a fuss, or they don't die while they're doing so much drama. So for the men, they have sodium channelopathy and they die while they are sleeping. The females, they usually die while they're doing activity, and they usually die from a potassium channelopathy, not a sodium channelopathy. It's important, again, to recognize the different ECG phenotypes of the long QT syndrome, which is the broad-based normal-appealing T wave pattern, which is the long QT1, and the bifid T wave pattern of long QT2, and the long-onset peak biphasic T wave pattern of long QT3. And also important from an emergency medicine point of view is to recognize the T wave alternance, which is either an alternating T wave, one positive T wave and then one negative and then one positive and one negative in the same lead, or you have different variability in the amplitude, and both are actually an imminent sign of imminent death. So this patient, if you have a patient that comes to you with syncope and then you do an ECG and it has a long QT and you see this biphasic T wave that's happening, like positive and then negative and then positive and then negative, you have to know that this is T wave alternance, and this patient should not go home till you really fix this. There are, of course, diagnostic criteria of the long QT syndrome, the Schwarz criteria. I'm not going to go through this. We go to something more interesting, which are what we're going to see as Egyptians. And what we usually see is something different. And we see it a lot, and I know, Professor Mervat, this is your case. There are two Egyptian siblings from Qina, presented to Aswan Heart Center with inherited cardiomyopathy clinic with their mother. It was a 6-year-old girl and a 5-year-old boy, and both were followed very well with Professor Mervat. And Professor Mervat was already putting both of them on beta blockers. And this is the ECG of the girl while she was on beta blocker with a very long QT of 530 milliseconds, and the girl, despite of having a very good dose of beta blockers, she was syncopal. What's interesting and what's important about these, the boy and the girl, that they were deaf mute. So, and they have a very strong consanguinity. If you look at the family pedigree, if you have a double line in the family pedigree, this means that you have the consanguineous parents. So there were like grandparents who were cousins who married each other, and then they had a father, like a son, who married his cousin, who had a son who married his cousin, and then they had these children. So these children have a long QT with that's very severe, that very resistant to beta blockers, that shows very strong syncopes and recurrent syncopes despite good beta blockers, and at a very young age. These are not autosomal dominant long QTs, but rather autosomal recessive long QT syndrome, which is called the Jervell-Lange-Nielsen syndrome. So the Jervell-Lange-Nielsen syndrome is characterized by congenital profound bilateral sensory hearing loss, long QT interval on ECG and ventricular arrhythmias. And it was first described by Anton Jervell and Fred Lange-Nielsen in Norway in 1957, and it was discovered in one of the very northern islands in Norway, where everyone had to marry from within it. So that's why there was also very complex level of consanguinity in that island where the JLNS was discovered. And it's caused by homozygous or compound heterozygous mutations in either KCNQ1, which is affecting the alpha subunit, or KCNE1, which affects the beta subunit in 10% of the cases. And now we know that in a very recent study that the KCNE1 are actually not phenotypically positive, but rather just a discovery. So it's mainly affecting the KCNQ1 genes that affects the alpha subunit of the potassium channels. It's a rare disease. It affects only 1 in 1 million. However, in Egypt, it affects much more than that, and I'll come to that in a minute. And what should we do to the sister or the brother? That's from a clinical point of view. And should they have the same treatment strategy? This is just to show that they are autosomal recessive. And what we know about when we compare between the autosomal dominant and the autosomal recessive long QT syndromes, we know that the autosomal recessive, they have much worse prognosis. Kids die at a much earlier age, and they are resistant to beta blockers in a much stronger way. So should we give beta blockers and that's it? Or should we do left cardiac sympathectomy? Or should we put an ICD in a 6-year-old? Should we do it on epicardial or transvenous? That was a clinical question. So what we did was that we convinced the mother that both kids should need an ICD. However, while the girl was waiting for her ICD to come, unfortunately she died at home. That was like after 1 week from our clinical visit. And so we brought the brother and we implanted the ICD for him, and we upgraded the beta blockers for him, and this is the ICD for the child. And from an electrophysiological point of view, in a 5-year-old, should we put an ICD with a small volt, like joules, 5 or 6, like 10 joules, or should we go for the big 6 weeks of follow-up? Is that the patient actually developed VF, and then he had that shock. He felt it. It was an 10 joules, and it did not cardiovert the patient. So we've learned that actually the patient feels everything. He will feel the 10 joules and he will feel the 35 joules, so just go ahead and do the 35 joules. Of course, in a long QT, there's no need to do ATP whatsoever, because the patient goes to Torsades de Pointes, does not have monomorphic VTAC, and we've learned that along the way. So we decided to go for a program, because that was the first case that we found, and then we decided just to call everyone, and if you have a child with deafness and syncope, please refer it to Osana Center. And so far, we have collected 12 families with 15 patients. And I'll be humble and say this is actually the largest in the world. And it's not something that we're proud of, but that's the truth, is that because of it's deeply cultured in our Egyptian culture that we have consanguinity everywhere, especially in Upper Egypt. And we have seen many families, like this case. Then you can see here the T-wave alternance that I was referring to, with a negative T-wave and then a positive T-wave. And that kid was only 18 months, and we had to be a little bit creative in how we put the ICD with the help of the surgeons. And that kid had so far 25 shocks. And he also, again, something that we learned along the way is that this kid had the cochlear implantation for him. And once he had the cochlear implant, he had so many shocks. He had like 15 shocks in 5 days because he started to hear. And as we know, auditory stimulation actually affects the child. And then he came to us with the battery finished, because that was 2 years ago. Now he's nice and he's like 5 years old. And one of the things that one of my colleagues did is that he actually lowered the sensitivity of the cochlear, and that actually lowered the event rate. So you have to be a little bit creative in problem management. Again, that was another case, and then another case. I'll just end up with the last one that we had. That was actually 1 week ago with a 2-year-old female with a history of sudden deaths. And the father actually did CPR to her at home. And she comes from a very strongly consanguineous family with 4 dead siblings and a very young age. And we also, again, we put the ICD in the abdomen, and then we put the pace sense as the regular epicardial lead. and then we use a defibrillator lead, but then we have to use a DF1 instead of a DF4 battery. So this is just an important point to take notice of, and that it is doing well, and we're following her up, and she's doing fine. Going to the Brugada syndrome, which is a sodium channelopathy, and it's characterized by ECG pattern of high takeoff, right recording leads, and ST segment elevation. The part of the J-wave syndromes that Dr. Osama will talk about, we have ventricular fibrillation leading to cardiac arrest in a structurally normal heart. So we know that there are about 10 genetic malfunctions that are mutations that cause Brugada syndrome. I'll just give you also again a couple of my own cases that this guy had one of his colleagues died suddenly. He's an air pilot, and he did this ECG just to a regular check. And I told him when he did this ECG were they placed? Did they place the V1 and V2 here or were they here? They said, no, they were actually up here. So that raised a suspicion for us. So we did a flickonite test for him, and it was negative. So, and we just redid the ECG in the normal placed places in the fourth intercostal space, and you can see that the patient actually has more or less a regular normal ECG. And so this patient we are reassured. We had a case again last week. Last week was quite interesting in Aswan. We had this ECG of a patient who was he was a 40-year-old male during normal activity, and you can see that he just has this funny-looking V1, V2, but does not really classify as long QT type 1. Brugada type 1. So we did a flickonite test, flickonite provocation test, and you can see V1 and V2. As I hope everyone in the audience can see the difference between that and that. So the next question for him, should we put an ICD or not? Who would vote for an ICD? Family history of sudden death, but not spontaneous. Not spontaneous Brugada, not spontaneous type 1. Yes. Well, if we look for the literature, we know that from the finger trial, only spontaneous. We actually vote not to even do a sodium channel block. So I did actually against what we recommend that we do the sodium channel blocker test. And if you look at the ICD recommendations from the American and from the European, is that if you don't have a spontaneous Brugada syndrome type 1, you do actually nothing, just do closed follow-up. But if you have spontaneous, then you can go for an EP study. In that particular patient, what I voted for is that he has a risk, and he's Egyptian. He's not either European or American. So we never had systematic. So we don't know what our genotype phenotype association would look like. Can I have 3 minutes? So what I decided to do is go for the next thing is to go for programmed ventricular stimulation, and then let's see. The patient is not really happy to implant an ICD, so that's also the patient's. That would be excellent, but we're not Brugada, we're not Capone. That's it. Short QT, just one word is that you always have to remember, you have a case, I think, from Ain Shams, in a young patient who has AFib and with family history of AFib or sudden death, you have to always think of the short QT syndrome as one of the differential diagnoses. This is something that you have to always remember. And for CPVT, this is also again a child that we're following up in Aswan who has CPVT. You can see that he has bigeminal like biphasic VTAC during activity. We've been following this patient, and we just gave him beta blockers, and now he's on flickonide and he's doing fine. And we are trying to postpone the ICD as much as possible. Thank you very much. And again, I finished with aphorism from